Distinguished guests, honorable speakers, ladies and gentlemen, good morning. I'm pleased to welcome you on the fourth plenary session about healthy urban planning, measurement and metrics, data, research and education. The session will be chaired by Professor Gerard Salem, Emeritus Professor of Geography of Health at the University of Paris in France and member of the Scientific Committee of International Society of Urban Health and International Geographical Union. Please give a warm welcome to Professor Gerard Salem.
Thank
you. Joining him in this session will be our distinguished panelists. Professor Billie Giles-Corti, Distinguished Professor at RMIT University and Director of its Urban Futures Enabling Capability Platform in Melbourne, Australia. Please give a warm welcome to Professor Billie Giles-Corti. Professor Waleska Caiaffa, Professor of Epidemiology and Public Health at Federal University of Minas Gerais School of Medicine, Belo Horizonte, Brazil. Please give a warm welcome to Professor Waleska Caiaffa. And finally, Professor Tolullah, Associate Professor and Public Health Physician Specialist at the Division of Public Health Medicine, University of Capetown, South Africa. Please give a warm welcome to Professor Tolullah. Dear speakers, I wish you a productive session.
Okay. Thank you. So we are a little bit late, so we'll start immediately. So very briefly because of 7 reasons. No, it's a joke. Don't worry. So the theme of this panel is healthy urban planning, measurement and metric, data, research and education. So many concepts, so many words, and of course we could add another concept with the key concept, the concept of equity, the themes of the conference. So, Billie, you are the first one.
Okay, thank you.
15 minutes, 20 minutes, thank you.
I'll try. So I've titled my talk, Could City Planning Metrics Help Achieve the New Urban Agenda? And to tackle this topic, I thought I would present some of the work that we did with Lancet series last year that was published on urban design, transport and health to contextualise really what my argument is about the upstream determinants if we want to achieve better cities and better outcomes for cities. I should have acknowledged my co-authors there, particularly Mark Stevenson, who was the series lead, and Jim Salas from the Australian Catholic University. I led the first paper on city planning and health and brought together a team from across the globe from high, middle and low income countries. And we contextualised the series initially from the perspective of the UN Sustainable Development Goals and said there's global recognition now about the importance of city planning for a whole range of reasons. But if you look across the Sustainable Development Goals, you'll see that there's around 9 goals and 24 targets which specifically talk to this topic of city planning and health. Of course, it ties into the UN's Habitat 3 New Urban Agenda around cities being the place where we need to deliver on Goal 11, which is around sustainable cities. And it's interesting when you look into the document about the whole issue around cities, and it talks about the need to change the way we plan, design, manage, develop, govern cities. It's a really big agenda. Now, it's also picked up, of course, by the WHO, which has for decades now had a focus on healthy cities, but this was reaffirmed in their meeting last year in Shanghai, their 9th global conference on health promotion. And it made the point, of course, that cities are a critical place. It's where we live, work, love and play, and they're important settings for health. And it also makes the point, which I think is a really important one, that health should be one of the markers that we've been successful in, a city's been successful in sustainable development. Now, in addition to the big picture sides, rapid urbanisation, population growth, we contextualise the paper around cities in terms of the big global agendas. Not only are cities in the lower middle income countries still dealing with non-communicable diseases, they're now actually tackling, of course, chronic disease. So rising levels of chronic disease, depression, Road traffic injuries, 8th leading cause of death and disability globally. But of course, with economic growth and people taking on cars, there's also air pollution, chronic noise. Social isolation is becoming a big issue in cities, and that's been exacerbated by fear because of crime, so personal safety and fear of crime. And of course, the major issue that we're dealing with and discussing at this conference is around growing health inequities. So cities are dealing with really big issues that we have to tackle in the 21st century. Now, what Lance has asked us to do with this series was say, they didn't want us just to go and say what the problem is. They wanted us to go beyond the what, and we focused, of course, on this series on urban design, transport and health. And one of the solutions, of course, for chronic disease is to encourage walking, cycling, public transport use as an alternative to driving. And that's really what we focused on in the series. How could we achieve that? And what Lance had said to us, we want you to go beyond just describing the problem to move forward, and how do we go about achieving that? So we looked at the literature, and we've come up with the need, if we're going to really be serious about increasing walking, cycling, public transport use and decreased driving, we needed to have 8 integrated transport and planning interventions. Now let me talk you through those. We drew very heavily on the work of Reid Ewing and Bob Severo, who are transport and planning academics, who talk about the 5 Ds. And we created the 8 Ds, and we looked at them in a very different way to traditionally the way they're looked at. So first of all, in health, what we've tended to do, and certainly in my area of looking at urban design and cities, is to focus very much on the local urban design. So the design of the street networks, whether they're connected, whether people can get to different destinations easily, whether there's footpaths present, whether there's cycle paths present, and whether we've made them so that there's easy access to public transport. The other element of urban design that's important is density. So in North America and in Australia, where I come from, there's a big focus on too lower density on the urban fringe. But of course, there's equally the issue of too higher density, which a lot of cities are grappling with, and that causes certain subgroups, particularly vulnerable subgroups, to attenuate their behaviour, to actually do less physical activity. Distance to transit, so do people have good access to public transport, and is it closely available? The diversity of the different types of destinations that are available in a neighbourhood, because they're the reasons why people walk, but also the diversity of different types of housing, because when there's more diverse housing, it actually increases the density. And then something that's not really dealt with very much by transport planners or even planners themselves is the desirability. And people in low and middle income countries really pushed us in trying to include this in there. And this is to do with desirability was related to personal safety, traffic safety, aesthetics. Is it a pleasant place for people to be physically active? So this was the local urban design. Now, I guess I've been doing this work now for a very long time, and it's pretty clear that whilst local urban design is really important, if we really want to achieve better cities, we also need to think about metropolitan regional governance, and particularly regional planning. And we've included in our 8 Ds 3 related to regional metropolitan planning. The first of all is destination accessibility. Can people easily get to work in public transport in a timely way, not having to spend hours on public transport? And that's important for the second element of the Ds and the regional planning. It's to do with the distribution of employment across the region. Do people all have to travel into the CBD and spend hours travelling to get to work, or are they able to get to work locally? And demand management. If we really want to increase walking, cycling, public transport, if it's too easy to drive, if it's too easy to get parking, if parking is very inexpensive, well, of course, it's very hard to control demand for the alternative. Now, we see this as a package, and they will be delivered in different places, obviously in very different ways, depending on the cities. But what was important about this is, because we were pushed by Lancet, what they asked us to do was, well, it's all very well to say that, but how do we actually achieve that? And so we wanted to go a step further. And what we argued in the Lancet series is that if we want to achieve these interventions downstream, then we have to think about the upstream policies that create those interventions. And traditionally, of course, we've looked at transport and land use types interventions. Even that is hard to achieve in an integrated way. But in addition to that, we've talked about employment, local employment. Then we need policies around employment and economic development, housing policy, social infrastructure policy, where we're going to put the social services, the health services, our educational services, public open space and public safety. And what we argued is that we really need integrated planning across all these urban systems if we want to produce a better outcome in cities. So here are the urban systems on the left, and what they do, the decisions that we make, the policies that we have upstream will deliver the interventions further downstream. Now the reason why, of course, these interventions are so important is that they affect our transportation mode choices and our daily living outcome. And so in terms of the daily living outcomes, the decisions that we make upstream around these policies and the interventions that they produce, it'll affect whether or not we've got access to education and employment locally, whether we've got food and health services locally, whether we have social and recreational opportunities locally. And that will affect our demand for the alternative to driving, so whether we have any aspiration or the social norms about how we get around in our communities. And that will affect our transportation mode choices, so whether we walk, whether we cycle, whether we use public transport, and whether we drive. Now, the reason from a health perspective that these decisions, the transportation mode choice is so important, is quite complicated. It affects what we argued was 8 risk exposures. 3 of them are environmental risk exposures, 2 of them are social risk exposures, and 3 are behavioural risk exposures. Now let me just talk you through those. The reason why risk exposures are so important is because they affect intermediary outcomes and then long-term outcomes, and then ultimately our health and well-being. Now let me talk you through. Why is traffic such a big issue? Well, of course, more traffic incidents affects road trauma, and as I mentioned earlier, it's the 8th leading cause of death and disability globally, and rising. But traffic's also important because of air pollution, and air pollution is important because it affects greenhouse gas emissions and particulates, and that has a whole range of health impacts more downstream. Respiratory problems, heat stress, infectious disease, mental illness, chronic disease, increasingly being recognised to be related to dementia. So obviously air pollution is a big issue. But of course, traffic's also important because of the impact on noise in cities, and noise is increasingly becoming a major issue in noise. And it's also important because if we're designing our cities so as people are spending a lot of time in their cars and not in their local communities, it increases social isolation, and together with noise and other factors, it impacts on mental health. But social isolation is also affected by people's sense of safety, and we see a rising issue in cities around people's fear because of growing levels of crime and violence. And if people constrain their behaviour, they're less physically active, prolonged sitting and healthy diets work together on overweight and obesity, chronic disease, and then ultimately, again, health, well-being, sustainability and livability in our cities. Now, why is this so important? It's a system. And unless we think about what's going on upstream, it's not going to create the conditions downstream that will create health and well-being. Now, what we argued then in this, and again, we were pushed by Lancet on this, and it was quite exciting to see that they really wanted us to push this, but what they argued and what we argued in our Lancet series, what gets measured gets done. And what we needed to be able to ensure that we had better cities is the creation of city planning indicators. Now, this is a map of Melbourne, the spatial distribution of Melbourne, and you can see that where it's green, it's highly walkable. And anywhere from yellow through to red, you wouldn't expect to see too many people walking. So Melbourne is one of the more livable cities in the world, so it's said. But actually, if you start to get out to the fringe, what you'll find is that most people are driving because that's actually been the way it's been designed. So again, coming up with benchmarks so that we can actually see what's happening in cities. Now, what we argued, not everyone is going to have the data for being able to produce spatial maps, and we're very conscious of that, particularly in low and middle income countries. Access to GIS data may not at the moment be available, but there is things that we can collect for cities, across all cities, to provide some metrics. First of all, we can have metrics around the legislation and the policies in a city that would create these good conditions. For example, do cities have policies and legislation around air quality? Do they have policies around urban design or integrated planning that we've argued is necessary? We could also be collecting across all cities how much government expenditure is there on the different modes of transport? Are we putting all of our money into roads you could work out per capita? How much money are we spending on roads compared to how much money we're spending on public transport, walking and cycling infrastructure? And then, of course, we could be measuring the policies around urban and transport planning and design interventions and their outcomes. And then, of course, then we would have the transportation outcomes, the risk exposure outcomes, injury and disease outcomes. And in an ideal world, in places where the data is available, this could be spatial, as we've shown with the Walkability Index, because then we can see inequities across the city. Who are the winners and who are the losers? Now, I want to sort of go through a little bit about how this could work in practice. And again, I'm using an example that we have developed in Melbourne, Australia. And what we've been doing there is measuring measures of urban livability. Now, the reason why we have got into livability is because it's a highly valued element of city life in Australia. And when I first moved to Melbourne, I was asked by the health department, who was concerned, just to give you a sense of this, Melbourne's population is doubling by 2050. That's the estimates, and the rapid growth that we're experiencing on the urban fringe is causing the health department to get very concerned about the lack of infrastructure that's being delivered to people who are living in affordable housing on the urban fringe. So when I got to Melbourne, and Melbourne has now been ranked for the 7th time in a row, 7th the most livable city in the world, people are getting really quite carried away that this is for everyone. But of course there's incredible inequities, but it's something that's highly valued, and so that's really why we latched on to the idea of livability. I was working at the University of Melbourne at the time, and we had a team of us got together in Butterworths here at the conference, and he was one of the ones that really got us into this area. Hannah Badland is also here. And we started to think about, well, what is livability and defining it? And then we got some funding through Centre for Research Excellence in Healthy Livable Communities, and Hannah Badland led an incredible program of work where we started to look at how do we measure, conceptualise and look at the relationship between health and these different domains of livability. And she worked with a very large team of people who worked locally and also nationally to actually start to pick up and run with this notion of livability. So first of all, how do we define livability? We said, well, a livable community, and we looked at all the literature across the globe. It's talked about a lot in public policy discourse, as well as academics and cities talk about it. It's talked about by the OECD, but no one really defines it. So we defined it. Well, we said, and you'll recognise these are the social determinants of health, but not talking about the social determinants of health. So we said a livable community is one that is safe and socially cohesive. It has to be environmentally sustainable. And it does have affordable housing, a big issue in cities. But it's no point providing the affordable housing on the fringe if it's not linked by walking, cycling and public transport infrastructure to employment and all the things that you need for daily living. Now, the delivery of that, of course, will depend on where one lives and the sorts of cities that you live in. But nevertheless, it's hard to argue that everyone is not going to need these basic infrastructure. We regard this as the social determinants of health, but we don't talk to our policymakers about the social determinants of health. We talk to them about livability. Now, what we've done is we've looked at the different domains. We haven't measured at this stage all those elements of livability, but we have picked up public transport, social infrastructure, employment, walkability, housing, public open space and air quality. Actually, air quality was something that our international advisory group asked us to put into it. But anyway, we've been looking at it, and what we've been doing is measuring these different elements and testing them out, looking at the associations with health using GIS data. And each one of our domains has been policy relevant. So we've looked at the policy within the state and said, what are the policy trying to achieve? And we've looked at whether or not this predicts people's health outcomes. So for example, in Victoria, the policy is that we should live within 800 metres of a train stop, 600 metres of a tram stop, or 400 metres of a bus stop. And so we've said, well, this is our measure of proximity to public transport. And we've done that for all of our different indicators. This is our spaghetti map produced by Carl Higgs. But we love this because it's a way of describing the complexity of all the data that's gone in. And what we've been working on is creating a livability index, an alternative index to the one that the Economist Intelligence Unit uses to describe cities, which doesn't tell us anything about distribution within city. And what this allows us to do then, by putting all that data together, anything that green is quite livable, anything that's sort of white is just like average levels of livability, and anything that pink is below average. And so what we've been able to do with this is now we're testing this out to see, well, how does this relate to health? When you've got all these different amenities in a city, what difference does it make to your health and well-being and your transportation behaviours? Now, the other thing we're doing with this was we're going that step further because we want to use this as the metrics as a city. So what we've been able to do is we're creating a portal where we're going to be able to, policymakers can go in, either local government, state government, federal government, or even the community can go in and have a look at the different attributes. So here we've got the Livability Index for an area called Flemington. It's got a very high livability index, it's around 90, and it's understandable why it is a high index. It's got reasonably good density, it's got access to social infrastructure, it's got very good access to public transport, and it has good access to all the other attributes. So that's why. But equally, what's probably more important is why a place is not so livable. And here we have another area which only got a livability index of 15. It only has 2 of 3 different sort of daily living destinations nearby. Of the 16 different types of social infrastructure that we looked at, it only has 6. It has very low density, only 10 dwellings per hectare, so very low density. So this is a diagnostic tool that can be used to benchmark and monitor any interventions that go in this area. So we feel that this is a very useful thing, and I must admit we're getting really good policy feedback from our policymaker colleagues because we're doing it in collaboration with them. Now the other thing we're doing is measuring livability nationally, and this is our national livability walkability indicator. So anything that's green is walkable, and you can see across most of these cities there's clumps of green, and that tends to be in the inner city. What excites me about this is that we see on the urban fringe of Perth, which is the second in from your left, that's Perth. On the fringe we're starting to see little walkable neighbourhoods. And what's exciting to me is because we've done a long-term evaluation there, we know that that's being produced because of good policy. So we're actually starting to give feedback, and so we can compare cities across Australia about what's been achieved in the cities. The other thing we've done is we've looked at the policies, and I mentioned they're very policy relevant, and we're trying to give feedback in our National Livability Report, which we'll be releasing in a few weeks. So we've said, well, what's the policy in Melbourne? And I mentioned that it's, that people live within 400 metres of a bus stop, 600 metres of a tram, 800 metres of a train stop. And on the left slide there, what we've done is for every residential parcel in Melbourne, we've been able to look at their access to public transport, and you can see that the dark areas are that's very good. It's got to about 87% of people have got access. On the right, what we've done is said, well, which suburbs are actually achieving the policy? The policy is that 95% of households should live within this level of access, and on the right you can see the suburbs which are the green ones, inner city. People on the urban fringe who probably need it the most have very poor access to public transport, and so we're able to show that. You can see it in the colours anyway on the left-hand slide, but now we're showing which suburbs are achieving it. And this, we hope, will become, again, this diagnostic that we can use to benchmark and monitor and see over time how it changes. So could city planning metrics help achieve the new urban agenda? I've said yes, but a qualified yes, and I think it really does depend. And let me talk you through why I think that. So what I've argued here is that to get these transportation outcomes, what we need is good integrated urban policies upstream, and then that's going to produce these range of outcomes, okay? So planning and transport interventions. Now it's interesting, what I've done is gone through and mapped the indicators that are included in the framework, the indicator framework that's been adopted by the UN to achieve the Sustainable Development Goals, and I've mapped them across our framework. And anything that's green is where there's an indicator in the framework, and what you'll see here is that there's a lot of downstream indicators. We want to get good public transport, but we don't have comprehensive policies upstream. We're not measuring anything to do with the amount of money we're spending on transportation infrastructure to achieve those outcomes. And unless we've got sort of sophisticated policymakers, as we saw yesterday with our representative from Cascais, Ricardo, we won't be able to get the outcomes downstream. So I think city planning metrics could help, but I think we need to be thinking about a little bit more upstream to make sure we're going to get the downstream outcomes for cities. So just in terms of my conclusions, first of all, what I've tried to argue, that no single policy or practice intervention is going to be enough to achieve the agenda or the Sustainable Development Goals or the UN, New Urban Agenda. And what's really needed is integrated city planning and interventions upstream that will determine downstream. What I've tried to say is that to achieve the New Urban Agenda, what we're going to need, or to actually put in a framework where we can make sure we're going to achieve the New Urban Agenda, we need comprehensive city planning indicators that are around the upstream determinants. And I think, and the interventions, and we could use these to benchmark and monitor how we're going over time to produce healthy, livable, sustainable, equitable communities. Now, I know that for many cities in the world, they won't have the geospatial, but I think at the very least we could be setting up the policy indicators to see have we got the policy framework in place. And I think if we can do this, it will actually help to keep us on track so we can benchmark and monitor over time if we've got the policy frameworks in place that will achieve the New Urban Agenda and the Sustainable Development Goals. I want to close by just saying again, acknowledging my co-authors on the Lancet series and all of our funders and collaborators on the work that I've been doing and whose work I'm presenting today. So thank you.
Thank you, Billie. So may I ask you the floor to keep that question for the end of the panel, and we will have a more global exchange and discussion. So may I introduce Professor Tolullah Honey? Tolullah, it's up to you, 20 minutes.
Okay. Thank you. Good morning. Good morning. Okay, not alone. All right, so I'm going to be talking, taking a slightly different approach, but as you'll see, I promise we didn't coordinate, and actually quite a little bit of overlap. So I'm talking about the role of transdisciplinary approaches and metrics in addressing urban health, particularly in the context of epidemiological transition. I will talk firstly a little bit about the transition, what we're seeing are changing patterns of disease, using South Africa as an example where I'm based. And I will describe very briefly, two projects that we have conducted using some of these metrics to really show the ways that these data can be applied. And then I will end with three approaches to addressing these urban challenges that we've either used and or we've recommended. Okay, so first the changing patterns of disease. What we see in South Africa, and this is something that we're seeing across many low and middle income countries, is that we're moving from largely infectious to actually a more protracted transition with an overlap between infectious and non-communicable diseases. This is just to showcase that. So this is the morbidity is measured by disability-adjusted life years, which measures the years of life, premature years of life lost and years of life lived with disability, and the changes between 1990 and 2010. So you don't have to be able to read anything, just to note that everything over the zero line is an increase, below the zero line is a decrease. Red is infectious, blue is non-communicable, and green is injuries and violence. So at first glance, you can see that over those 20 years, we're seeing the HIV/AIDS spike, because obviously it spans the pre and post the peri-epidemic, peak of the epidemic. But we're seeing a lot of blue go up. So we're seeing a lot of this increase in non-communicable diseases, diabetes, hypertension, anxiety, major depressive disorders, etc. So why is this remarkable? Well, firstly, because you're seeing this rise in chronic conditions in a public health system that is largely geared towards more acute episodic care. Secondly, because these diseases are coexisting. So where normally we say, yes, they exist, but they exist in different people, actually we're seeing that these are coexisting within the same people, so we're getting this rise in multimorbidity, which I'll talk about a little bit. And thirdly, because not only do they coexist, but they interact. And they interact in ways that then make the outcomes and the progression of the diseases less predictable. So just to touch on that notion of morbidity, necessarily because of this protracted transition. What we're seeing is a rise in the number of people with more than one condition, just highlighting some of the work that we've written around this, both in academic journals and in the conversation. I'll touch a little bit about this particular study, where we then, realizing that we're seeing this transition happening, but realized that we didn't have any data to really say, well, in what ways are they coexisting? Do we have existing data within the routine administrative data to look at this issue? So we conducted a study in one clinic in Capetown, where we looked at everyone coming through that clinic over a 9-month period. We used electronic medical records to look at the prescription patterns, to look at, well, what are people who received a prescription coming through an outpatient clinic over a 9-month period, what are the patterns of prescription? And one of the things we noticed was that just under half of prescriptions were due to one of these 4 conditions: HIV, TB, diabetes, and hypertension. So they were responsible for a significant amount of the burden of disease. The interesting thing we saw when we tend to look at, well, what are the patterns of multimorbidity? So we used in this clinic, in the province, each patient has a unique patient identifier, so we could track, well, who are the people getting prescribed what, and how many conditions do they have. And one of the things I just want to highlight is that so we looked at the patterns of multimorbidity for these 4 conditions: hypertension, HIV, diabetes, type 2 diabetes, and TB. So say, for example, we know HIV, TB coexist, we know diabetes and hypertension coexist. Firstly, we found that about a third of hypertension, patients with hypertension were multimorbid. Predominantly, that was diabetes. Interestingly, about 20% of the HIV patients were multimorbid. Again, over 3/4 of that was hypertension, which they're not diseases we often think about coexisting. So really, we started realizing that our health system was perhaps not sufficiently responsive to these changing patterns, because we still had a system with very vertical, siloed systems. The other thing we found, which I'm not showing the slide because of time, was that not only were the patterns of multimorbidity not as expected, but they were occurring in younger age groups. So we saw this rise in multimorbidity already in the 18 to 35-year age group, which is not the group that we think of as at risk of these chronic diseases. This is my spaghetti diagram, which is more al dente spaghetti, I guess, really to show that interaction between the infectious and the prevalent non-communicable diseases, again, to show how they interact. But more importantly, there you go, there's the spaghetti, to show that they actually have these shared risk factors with an underlying urban relevance. So we often think about these risk factors in the context of particular diseases, whereas in fact, what this diagram is not supposed to ask you to follow anything, but just to see that from the middle here, you have risk factors going in both directions. And you can see high blood pressure, air pollution, tobacco, socio-environmental factors, physical inactivity. These are really relevant to the rapidly changing urban context. So that was one study. The second I just wanted to highlight quickly was a study we conducted looking at, so we've seen this multimorbidity patterns. What are the spatial patterns of multimorbidity across the country? So we looked at a National Income Dynamics Survey. So it's a panel study that's been happening over the last 8 or so years across South Africa. We looked at a couple of waves, so comparing the wave of the data collection in 2008 to 2012. And it's a survey of over 28,000 individuals across the country. We looked at patterns of multimorbidity, but specifically hypertension. We wanted to look at the links with socioeconomic disadvantage, so we used the multi-dimensional poverty index as a proxy indicator for socioeconomic disadvantage into those categories. What did we see? Just to highlight deprivation, factors associated with multimorbidity, really unsurprising. Deprivation, living in an urban versus a rural setting, and obesity. And those were the three key factors that came out strongly as associated with multimorbidity. The other aspect is, again, the spatial inequity, and what I just wanted to pull out from this paper were the patterns that we saw of socioeconomic disadvantage across so this is South Africa, across the different provinces. The darker over here, the darker the color, the greater the degree of socioeconomic disadvantage. On this is the clustering of multimorbidity, and again, the hotter colors showing greater clustering. And so we started to see that these, in addition to the regression table, we could see the spatial clustering of both deprivation and multimorbidity clustering. So really starting to put together a strong narrative of the importance of the urban in driving some of these changing patterns of disease, and the importance of the spatial distribution in driving health inequities that we see across the population. So the question then is, knowing this negative, can urban exposure rather be harnessed positively to influence health? And if yes, how and by whom? So from the 8 Ds to the 8 S's of urban exposure, so I'm an epidemiologist, so I think about the cities in the context of exposure and outcomes. So trying to distill some of that complexity, thought, well, what are the key exposures when we talk about the urban as driving, as a health determinant? And some of the exposures, so the 8 S's, some of the S's make sense, some of the S's are a little bit contrived, but they had to fit into S's, so bear with me. So it's sugar and salt, and that speaks to the food environment and food systems, and we talked yesterday in the late session about some of that, how food systems and food system governance impact on health. Safe housing and social cohesion, which builds on Billie's point around social isolation and cohesion. Smoke and smoking, so air pollution, as well as tobacco smoking. Sleep and stress, speaking to noise pollution, speaking to the stresses associated with living in urban spaces. Sports and recreation, again, both in terms of largely physical activity or inactivity, whether it's for leisure or active commuting. Sanitation and water, fairly obvious. Substance abuse and alcohol abuse, again, which we see particularly amongst the urban poor as being at high risk. And sex, because this, you know, in the context of a high HIV epidemic, what we see is sex is still a vital, an influential exposure that is differential in urban, particularly amongst new urban migrants and the urban poor. On the other side, I showed, so in the South African burden of disease, we talk about the quadruple burden of disease, and it's similar in other settings. So we have HIV, TB, non-communicable diseases, diseases of maternal and child health, and injuries and violence. And really what I wanted to show, I'm not going to go through it in detail, but I'll just, as I talk through, what you can see is that there's urban exposures, they impact on these burden of disease in multiple ways. So when we start thinking about how to harness urban exposure for health, bearing in mind those complexities. So thinking about these changing patterns of disease, thinking about these urban exposures and the ways in which they influence health, established this research initiative, which is a loose collaborative and interdisciplinary, to really start to tease out these issues, bearing in mind this context of epidemiological transition and rapid urbanization. So we look at health systems and systems for health. In terms of health systems, we look at some of those multimorbidity issues and interventions solutions for integrated care and prevention of these chronic infectious and non-communicable diseases. In terms of systems for health, we look more at the urban environment and different components of the urban systems like housing, food, etc., and how those can be harnessed for health. And in the middle, we look at specific populations at the moment, so adolescents, particularly in the context of prevention. We know that almost 3/4 of behaviors that lead to NCDs arise in adolescence, and yet we seldom target them in the thinking about NCD prevention. And also migration and mobility, because we know that a lot of our cities are in flux constantly, and across the globe, the issue of migration and population mobility remains prevalent and is associated with health outcomes. So as a RISH collective, we have employed a couple of different approaches, which I'll just finish off with. In terms of the interdisciplinary approach, in getting started, we put out a call across the university to say, okay, who's working on urban health-related issues? Some people came forward voluntarily. Some people were coaxed because they do work indirectly in health and maybe not self-identify that way. To look at, well, what is our strengths? What kind of skills, what kind of disciplines do we have that could work together instead of working across these different faculties towards addressing urban health? And one of the outcomes from that particular workshop was really thinking through the research themes and priority areas that are relevant to the African continent that need to be addressed, but importantly, and really thinking about that across using the socio-ecological model, so not just at the individual level, but then going upstream, thinking about the group, the experiences, environments, and policy. And those are the themes of the papers there. I don't want to go into detail around it. But importantly, not just looking at awareness and associations, but moving really to more impact, looking at the policy relevance, looking at intervention models to address these thematic areas. The second approach that we've utilized is really this transdisciplinary participatory approach, where having then collected as an interdisciplinary group of academics, thought, well, how do we start? How do we start thinking about addressing these? But understanding the importance of early engagement with, particularly with population, policy and community stakeholders. So again, the similar approach. I think there was one year where most of my academic time was spent organizing workshops. So we organized a workshop, really invited representatives from across the policy makers across different sectors, from housing to health to transport to public works, etc., to education. Really get together to say, what are your priority areas? What are you working on? And where is the potential to work with you to address some of these, and how do they overlap with our thematic areas? And really building trust and legitimacy, aligning, understanding their policy processes, etc. And one of the key outcomes from that was the project that was presented earlier this morning by Amy Wayman on the looking at health in housing policy. So my almost final slide is this third approach, which is really thinking about data. So this is where the metrics come in. So in the first couple of studies I presented showed the potential for harnessing we used existing routine data that was being collected anyway, but to give us a sense of how patterns of disease are changing. But we know that this is a challenge across many low and middle income countries. And so we have advocated for and are working towards really moving almost from a health surveillance to a health equity surveillance, where we integrate health and social determinants of health indicators into one surveillance system. Because that helps us see the big picture, helps us see how patterns are changing, how equity is changing in a more holistic way. But the key challenge with this, and this is something we're finding, is that it needs to cut across sectors, and those data need to be interoperable. And these are some of the challenges that we have to overcome. But the potential really for this kind of precision public health approach, and this is not just borrowing from the precision medicine speak, to look at really collating individual, group, environmental data for health creation. And I'm trying to move from prevention speak, so which focus on disease, to creation speak, which focuses on health. And some of the experiences that we finding with housing and health really is really identifying some of these barriers, working on that trust and legitimacy, working on how to develop these intersectoral data that are interoperable in a sustainable way. So what we don't want to do is just collect data that we collect because we conduct a study that can't be collected again without millions of dollars. So I'll just end with this slide, and which is to say that really what we're talking about here is accountability for health. And within the context of the city, what I would love to see is move from thinking about health professionals as the doctors, the nurses, the OTs, the physios, in the context of city, to think about city health professionals as the farmers, the civil engineers, the architects, the teachers, I don't know what that is, the scientists and the politicians. And actually, these are the city health professionals. And it would be great if across that board we consider whilst they may be healthcare professionals that work within the healthcare system, in the context of the city, these are the health professionals. Thank you.
Thank you, Tolullah. Waleska?
Yes.
Please.
Yes.
Oops, I was going to say good afternoon. I just missed. Good morning, everybody. Thank you very much again for this opportunity to be here. I'm very glad that I've been anticipated by my previous colleagues in this lecture, because during their lecture, Billie and Tolullah, I thought, I don't have any contribution for, this D's and S. So I started thinking about that, and I think I came up with something. I'm talking about, if I could change my title, an integrating intersectoral intervention for tackling inequity in an interdisciplinary way. Thank you very much. So, I will address some key queries before we'll present to you the Belo Horizonte Observatory for Urban Health and how we are creating evidence for action in policies and programs. And I will be sharing with you two experiences that we've carrying out with the municipality from a city level to a national level intervention, and also it's an upgrade program and its effect on health of dwellers, which is an intervention in Belo Horizonte. So now we are moving to South America, Brazil, Belo Horizonte, but still we have to think about to address the same problem or the same queries. Urbanization amplifies health inequalities, and cities need information. And I hope be convinced by my previous colleagues, you are convinced that cities, they really need information for monitor health and health equity, to guide the local interventions and to evaluate if intervention improves health and reduces inequality. So the Urban Health Observatory is given the lack of very good inter-urban level data and the absence of an integration from and beyond the health sector. Observatories may be an institutional mechanism for collating and analyze data, relevant data, in order to generate useful intelligence for policy making. So we are an observatory for urban health. We are an adolescent institution right now. We were founded in 2002. We are a bunch of academics, professionals from health and non-health sector, engaged in studying health outcomes within the city. We are nested at the Federal University of Minas Gerais, and we have a very strong partnership with Belo Horizonte municipality. And also we are a collaborative center for the Ministry of Health in Brazil. This is how we frame our studies. We are very oriented towards project-based studies, and we use the framework for urban health, thinking about the macro level to the local level in terms of what are the interventions, thinking that the politics or the decision could be macro, but the action will be local as ever. So thinking about that, we have this point in that we want to understand the intra-urban effects, and this is what I'm going to try to show you a little bit. This is our study scenario. We are in Belo Horizonte, the 6th Brazilian largest city. We have 2.3 million population, and it's a beautiful city called Belo Horizonte, means a beautiful horizon, but still we have almost 20% of people, residents living in slum, in vulnerable area. As you can see, we do have basic sanitation, a very good coverage, but still we have problems. The framework for urban health evidence evaluation we've been adapted from the Mendy Panat Rochana, this is a very young scientist, and we are trying to understand the interventions, thinking about the context in terms of the demographic factors and socioeconomic factors, as well as the natural social building environment. But through some mechanisms, including in territorial inclusion, so we can look at some health outcomes, behavior outcomes, risk exposure outcomes. So the first example is the fitness center in Brazil, which is in the origin, it was a city-level program named Programa Academia da Cidade. This program was designed for tackling the non-chronic disease in the city, and was putting in the agenda of the city, the health promotion and promoting more active lifestyles. This has been in place in Belo Horizonte since 2006. And the idea was that the community intervention aiming to increase levels of physical activity is an important strategy in mitigating inequities in the determinants of health. So, it's a public citywide intervention, and the peculiar thing here is that it was designed for a priority to be implemented in priority areas of high vulnerability to health. And here we can see how data is important in terms of to determine the spatial vulnerability of one, let's say, one territory or one city. And also, the characteristic of the intervention is universal access, because it's linked to our health system, which is a unifying health system that it's open to everybody. So the idea was to build environment with a simple structure for physical activity or other health promotion activities, and designed to address health disparities for non-chronic disease. And as I said before, located in the private urban neighborhood as part of the urban planning and participatory budget process. So as I was anticipated by a colleague, we need data, but we have to understand how we're going to use data in terms of good way. So this is how the city fitness center looks like. Usually it has 400 participants by center. Usually it is more than 18 years or more, the adults, and they use 2 or 3 shifts a day. This is the picture of the people. And as you can see, this is a very interesting picture because we catch here in this picture who is participating in this specific program. So the picture speaks for itself. So in the beginning, as I said, the implementation was in 2006, and we came in the field in 2008 for evaluating just 3 points in the city by that time. So you can see here there was one that was constructed already, and the 2 others that were not constructed but planned to be that. And then you see in the map as well the vulnerability of the census tract in those points. So the first thing that we looked at was that the built and social environment were better ranked by those living close to the fitness center. So the strategy was not evaluate only those that were participating intensively in the daily routine physical activity, but we did a household survey using some sampling strategy in order to try to understand the effects or the possible effects of that intervention in the neighborhood in terms of those who are living there. So as you can see here, we residents who are living in a closer distance to the building physical center, they evaluate better the built and social environment than compared to those who lived in a greater distance. So distance is very important, as was mentioned before. So you see that they reported seeing people exercise much more than when they were living close to the intervention, compared when they were not living close, and the places where there was no intervention yet. They evaluate, of course, public sports and recreation areas, but they also evaluate the streets and sidewalk maintenance, street lights. They report there was easy in walking around the neighborhood. Also, they have social support from friends and family for physical activity. So moving a little bit further, we decided to do a propensity score, which is an analysis that we could compare the same data, but now we compared the exposure one, that's the left side from you, and with no exposure residents, and we see this nice trend toward the 500 meters close to the exposure area as when we compare to the ones that were not exposed because there was no exposure. And when we see in this analysis, we can see this interaction between the existence of the intervention and the distance that the people or who were in the survey were living, showing that people who were living closer, 500 meters closer to the intervention, they were 1.2 times more likely to achieve the level of physical activity, leisure physical activity, compared to the other ones who lived farther away. So this study may provide a piece of evidence suggesting that intervention, especially designed for promoting community physical activity, may favorably affect the levels of the residents living in the catchment area, independent of their enrollment in the program. Of course, this is a very small piece of work, but as I said before, it's a local possible evidence for that. And what we have so far, this fitness center program in Brazil now, they scale up from a city level program to a national level. So we have this strong legislation in order to implement around Brazil units similar to that. And right now, we are, as a model, we're evaluating this intervention, again in Belo Horizonte, but in a larger sample size, include all the city, and see if we can repeat and find the same evidence. Well, moving to another intervention in the city, I'd like to share with you a little bit this project called Projeto Vila Viva, and the evaluation project is called BH Viva Project. As I said, as I mentioned in the beginning, we have about 20% of the population is still living in urban areas, in slum areas of the urban city, and as you can see here, with a lot of vulnerability, especially high geological and geotechnical risk. Belo Horizonte is a very mountain city. That's why it's a very important in the city planning process. So the intervention started in 1983. So you see that there is a long historical prospect. And the project was implemented in 2005. And in 2007, the local program, which was financed by some international institutions, was assimilated by the Growth Acceleration Program, which right now, it's almost dead in our country. But anyway, at that time, it was flourishing, and it was a good opportunity. So, the intervention in this project is based on a community participatory study, so it's not a top-down intervention of the municipality, aiming to list all problems and possible solutions together with the population. And it included a physical intervention with a very strong environmental urbanistic recuperation, a social organization with a social development, as well as juridical legal with a land tithing. The idea was to legalize, between commas, the slum area. So we came late, as usual, for urban health impact evaluation, aiming to assess the impact of urban intervention and looking at, initially, some health outcomes. But in the second phase, which we just finished the first field 2 months ago, we also are looking for some risk exposure outcomes as well. So using a secondary database, we've been looking for some health outcomes such as asthma, external cause, pregnancy in adolescents, dengue fever, homicides, among others. This study is a natural experiment with a mixed methods. We use quantitative and qualitative approach, and using this big data where the data warehouse we've been organized. So, as I said, we have several different sources of information, data information, and all information is geocoding through the census tract. And as I mentioned before, the phase 2 household survey, we just finished the first round. So this is one example that has been presented in this conference by one of our students. This is the teenage pregnancy. We are just assessing the time trend of the events, comparing, let's say, slums which have been intervened, the blue one, with slums that are not, still did not receive an intervention, with what we call the formal city. So you see the percentage of teenage pregnancy is really different from either the formal one, the formal city, compared to the slums in terms of case and control, or case or intervention and not intervention. Also, we've been looking at some hospitalization for asthma in children under 14 years old, and we see the same picture. We see the formal city, the lower line, the blue line, and see the lines in the slum. In this way, we compared high and low and medium and high vulnerability areas using some index, urban index. Again, we can see some profile for hospitalization for accidents and violence between age group. And also presented here the hospitalization and mortality rate among elderly, which is it gives a very intriguing picture, because here we see hospitalization rates are higher among those living in slums as compared to those living in the official city. And this we are trying to understand, and very preliminary. This is the spatial map for dengue disease, and we have the risk of dengue in these areas are 2 to 3 times more compared to the formal city. And on the other side, on your right side, you see this striking picture of homicide rate by age group just for children. And when we compare the line, the red one in formal city compared to the slums area. So you can see that after 12 and 13 years and more, we have this very, very risk of mortality by homicides in those children. I'm finished. So we've been trying to analyze in more deeper way the impact of this intervention. We've been mapping the intervention, each intervention, which has been a very huge amount of work, because we are, recuperating what were the intervention, when they took place, when they start, when they finished. And this is one very brief case study that we can see here, the interventions marked on all kinds of intervention. And here how we look at this intervention in terms of without intervention, the red one, when the intervention starts, the pink one, and when the intervention finished, the blue one. And compare the line, we see the homicide rate compare over time. And we see this intriguing pattern when we decrease, after that there is an increase, and after that decrease again. So we're trying to understand that. And when we plot these cases in a case study, and this is going to be presented tomorrow in the morning, so keep posted. And we compare the density of case using pre and post intervention period, we can see this directional trend towards the distance, to get distance between the intervention. We'll say, wow, the intervention is not working, it's just, just put away this thing. But we have to understand that the intervention or the rates were decreasing as well. So we have to think, with this find together. And in fact, that spatial displacement was significant when we compare the median distance. What it means, we still are trying to understand. Anyway, so finalize, despite several challenges, city is becoming the preferred habitat for humanity. I don't think we can argue against. And building block of the good city starts locally in the neighborhood, this is the iconic urban component where people and place come together. So we have to learn how to understand, it's how to measure, how to intervene, and how in order to keep or to tackle the inequities that usually take place in the neighborhood as well. So local experience of social and territorial inclusion represent a very powerful way for health equity, suggesting avenues for disease prevention and understanding how macro-level policies are modulated in order to turn in evidence for health. Thank you very much indeed.
Thank you, congratulations, Waleska. So, 3 complementary talks and 3 talks really relevant with the themes of the conference, I mean the equity. So in the first talk we have seen that all the new risk factors linked to the process of urbanization, and at the same time we have seen that there is no urban determinism. If we consider the inequalities between rural areas and cities, we can see that there are more differences between cities than between rural areas and urban areas. And very often there are more differences within the cities than between the cities. So no urban determinism. So it means that the process of urbanization is not only a challenge, it could be a real opportunity for health. And in the second talk, I've been impressed by how you show how urban places are the main places for epidemiological transition, nutritional transition, and so on. But the transition is unequal according to the different districts, and very often in the poorest district, there is a double burden of disease, as you know, and plus, with the process of globalization, modern poverty, we have also the big challenge of emergent disease and new emergent disease, including zoonoses and so on. And by the way, we have seen that the old classical categories we are used to have in public health, like youth, or elderly, or disabled people, doesn't mean, well, of course it means something, but it's not the main disability, the same disability if you were rich or poor, and it's not the same situation. So we have to link it to social and spatial inequalities. And then we have a very good illustration of a good observation of the situation and how this observation could help for mitigation of disparities. But by the way, it means also solidarity between districts within the cities, and it highlights also the fact that all the things which can be done at the local level and the links we should have with municipality and so on. So just I don't see the room, but questions? I'm sorry, I don't. So, could you briefly present yourself, yes. Say where you're coming from, and...
Good morning, my name is João. I'm from the University of Porto, north in the country. So my question goes to the first presenter, Billie. We're talking about livable cities here, and in your case, you're talking about Melbourne, which is the most livable city in the world. But I'm also here worried about what might be an anomaly or a a pattern for the future, which is Australians now have the highest ecological footprint in the world, which is 5.2 if everyone had that lifestyle. So my question is, if we are striving to move up in the spectrum of livable cities in the future, does that follow up with the city being more livable, also having more affluence in the lifestyle that we have and the ecological footprint that we all will have in the future as well? Thank you.
Thank you. That was a great question. You'll notice from our definition that we quite deliberately included that a livable city, that's why we've defining livability. So we found that there was very few definitions of livability, and we said that a livable community is one that is safe and socially cohesive and inclusive, environmentally sustainable. We actually at this stage haven't developed all the indicators around environmental sustainability, but with the new work that we're releasing with our National Livability Report, we're creating an urban observatory which will include some new indicators which will cover both resilience and urban livability and biodiversity and things like that. So I think the point's a good one. We also had out from Brazil a student, Priscilla Gonzalez, who what she did was start to look at livability from a lower middle income country perspective, and it's been something that's been of interest also in India. And what we've added into it is things like water, sanitation, and that sort of thing as well. So I think it's a very good point that you wouldn't want to replicate Melbourne's livability because it is not environmentally sustainable. And that's why we sort of emphasise the importance of having good public transport systems that can mobilise people from home to work, that sort of thing. Increasing density on the urban fringe, creating urban environments on the fringe of cities rather than continuing to build at very low densities. So I think you make a very good point, but certainly something that we're very conscious of, and we're not promoting the idea that everyone becomes like Melbourne, but actually what we really genuinely create is livable cities according to our definition.
Thank you. Another question?
My name is Fred Kent. I'm with Project for Public Spaces. The issue that a lot of this quantitative data does not really address is the quality of place. And I know Melbourne quite well, and I wouldn't rank it on number 7. I think it's a very special place. You're very good on urban design, but the actual quality of the places is not as high a level as your quantifiable data. My son disagrees with me on this, but he's been to Melbourne a lot too. We do placemaking, and placemaking has become a really big deal in Australia, but there's a difference between this. And most places may have good data about that, but not about the quality of the place. How do you?
Well, I mean, obviously the quality of a place is very important, and I guess what we've been trying to do is develop indicators of cities which are measurable and collected through routinely collected data so that we can constantly be updating, we can actually update them. So our plan is to replicate these measures over time, and it's a bit like what we saw with your work in Brazil, where you've been able to map changes over time. Yeah. But it's not possible to do that if we set up a system of metrics, which, while I agree with you around quality being really critical, it's very hard to measure those things objectively, and routinely. It requires maybe auditing or requires other data. We've done that sort of work, but it's very intensive. So we wanted to set up a system that would allow us to replicate these over time so we can monitor changes over time. But it's not to deny that placemaking and quality is really critical. It's just that it was hard to set that up in a metrics of the city approach where we could provide livability indicators.
Good question.
I don't know.
Just compliment Billie. We have, sometimes people ask us, well, you're not evaluating sewage water. Yeah, because that's the problem. We have some metrical problems in terms of using secondary data. I mean, it's very hard to find health outcomes related to, especially related to hospitalization. We still don't have a very good outpatient data, which is a problem. And also, we have to figure out some way, some index, something that we can ask the population how to do that in terms of urbanization and the trends and the water intervention in the city. So if someone has some ideas and can help us, it will be very welcome.
I think just on your point, actually, in terms of quality, though, I think where technology is going, with artificial intelligence and drones and all those sorts of things, I think there's, people who are doing work in this area where we are going to be able to measure things more easily over time with the technology that's being developed. So it's not to say that we can't do that over time, it's just that at the moment we don't have the technology to do that in a systematic sort of way.
Well, happiness is a great metric. People smiling, people touching each other. They come into a place and it feels good. Now, if you have more of those kinds of places, your quality of life, your health, all of these things improve. That's very hard to quantify.
Yes.
So how do we get that to be a core objective of the health community that really would benefit the most from that? The data sounds interesting. I love the data. But it's the place in the end that's going to make that. How they treated at the hospital, how they're treated in their neighborhood, and how they participate is a very big part of people's lives.
Yeah, I think we hope to, because since we have some qualitative approach as well, I think we hope to get some information on that, and we are looking at that, but still it's in process.
But maybe just to point out as well that two things. Firstly, that it's not for the health sector. This is the urban sector we're talking about. So across the different sectors should be interested in this as a quality of life. But secondly, to point out the contextual element, and it's something that was just alluded to in thinking about, well, what makes people happy? Also, there's a cultural context to that. And so when we think about metrics for quality of life, what may be accurate and relevant in Melbourne may not be contextually relevant in Cape Town, and Belo Horizonte might have different measures. So just the importance of thinking about quality of life in the context of what matters on the ground.
Okay, I've got one here which is directly related.
David.
Dave Lahub, editor of the Journal of Urban Health and Yale University. And one of the points that you just brought up is what are the metrics of happiness? And I remember a conference, it was around 2002, 2003, where it was public health people and architects that were together. And we asked the question, of the architects is, what's your metric? And theirs was public displays of affection, right? Unobtrusive measure, you just look, there's no survey involved. But if you're designing something and you see people, that are comfortable with each other and displaying affection, that was really a marker of a good design.
No, but maybe there is another question if you...
No, it's just where people take their shoes off.
Another question?
Okay.
Please.
My name is Blessing Mbero, APHRC Nairobi. I still want to go back to the index of livability and maybe complicate issues a little more. I mean, I'm looking at the history of urban planning in many post-colonial European cities like Nairobi, for instance. And by the structure of the planning, there are sections, westlands, eastlands. There are divisions of the city, and in most of the upscale neighborhoods is actually, you actually warned that public transport is not allowed in this area, okay? And it seems to me that people are really living well in terms of space, in terms of other indicators that you measured. But then public transport is really for the urban poor where there's a lot of concentration and so on. So I'm struggling with how to reconcile, for example, public transport as an indicator in that kind of context. And it's not just Nairobi, I see that across Africa, for instance. So I just want to bring that up and get your response or reaction to that.
Do you want to comment on that?
So yeah, no, I think that's a great point, and I think one of the things this highlights is the importance of thinking about equity or inequity in a complete context. So often when we talk about inequity, we're talking about the urban poor. Whereas in actual fact, we can't address inequity without seeing the city as a whole, right? Because otherwise we're creating a kind of separate but equal kind of space instead of thinking about how the city integrates as a functional unit. So what you're saying, you have a city like Capetown that has those similar remnants of spatial inequities with apartheid, where you have these separate things, and this is something I've been struggling with recently, that you realize we obsess about these spaces where the urban poor reside, but as a result of not thinking about inequity in the context of the entire city, it may result in that unintended consequence of actually keeping the different parts of the city separate. So what your example with public transport, for example, if we just look at inequity in the context of the urban poor, then we connect the urban poor. But meanwhile, we don't think about how public transport actually connects to the other parts of the city. So I think just in our consideration of inequity, what your question comment highlights the importance of looking at the city as a whole.
Which really directs us down to the issue of regional planning, like not just focusing local, but also thinking about the regional context, because the context as well. Because what I've come to realise is you can get really good local urban right, but actually it doesn't solve the problem, because really good local urban development not connected to the rest of the city actually means that you still reinforce inequities. So it requires that sort of really big picture, the combination of the two types of thinking.
Another question?
Can I say something?
Sorry.
My name is Tufail Ahmed. I am from Bangladesh. I have a simple question to the Brazil presenter. You conducted a cross-sectional survey, and a lot of data you have produced. I think since you have fitness center, right? You have fitness center, and you conduct a survey within the catchment area. So, do you have any regular recording and reporting systems in the fitness center? If it is there, then why did you not compare the survey findings and the regular reporting findings, and what was the data gap?
It's Waleska.
I couldn't hear.
Yeah, I would
just address to you.
No.
So,
could you just repeat that, but speaking slowly? It's just very difficult to hear down here.
No, I can repeat it. Cross-sectional survey is a one time. And based on cross-sectional survey findings, regular monitoring and reporting is difficult. It's one-time survey. And I think you have a regular recording and reporting systems in the cities, in your clinics or fitness center. Fitness center is a clinic, or what kind of service you are being provided there? That I want to know. And when you conducted your survey, did you consider the variables which are being recorded at the fitness center? And then, did you compare your data gaps to identify the data gaps between these two. Did you catch the point?
Would you answer?
So, okay.
Got it?
Yeah, thank you very much. It's a good intervention. I'm thinking how to look at this, because bring back the concept of equity and inequity. I'm not sure how much they complement each other in terms of one is the other side of the coin. I think perhaps there's more in this integrating thing. It's not like a straight line. One is, or this paradox thing, it's to be or not to be. So this is what I've been thinking about in terms of how to organize and to look at the city as a system with the lens of the equity/inequity.
Thank you, Waleska. Is there a last question? Very last one.
Last one over here.
Yes.
Good morning.
Morning.
My name is Caroline Kabaria from APHRC Nairobi, Kenya. My question is to still the first presenter. You mentioned something about spatial data sets and lacking in the lower middle income countries. What is your comment on how we would start collecting these data sets, particularly where you also mentioned integrating with policymakers? So we have new governments who are interested in making changes, for example, in the cities, but they lack support of data or data sets, particularly for the GIS spatial data sets where high-resolution satellite data still remains out of reach for most of these governments in terms of cost.
Yeah, the issue of data is not, I mean, it's even an issue in countries like Australia, which are, more wealthy countries. One of the things that, especially what we've discovered in doing the national livability report, is just how much variation there is in the way cities or states are collecting data. And it's almost like we need some leadership around trying to come up with some standards for the way we're collecting it. I know there is some work being done in Europe on this, so that trying to get by 2018 cities collecting data in a consistent way, which allows us then to compare cities, which is really challenging. We've found it very expensive to put together these data sets to be able to do this. And so one of our recommendations as a result of the report is that we need some leadership at the federal level to encourage cities to collect data in a consistent way with common ways of attributing the data, which would allow us then to do this more easily. What's happening in some countries, and Australia is one of them, is that there's a much greater push for open source data, that making data available to people. So if government departments are collecting data, making it available for research purposes. But even then, most of that data is not being set up for the purposes that we're using it. It takes a lot of work to clean them. So that's why I mentioned that not everyone is going to be able to easily create the indicators that we have. I think we should be pushing to get more spatial data, because the beauty of it is actually allows then to look at the spatial distribution across a city, which is the Hidden Cities report of the WHO. It's so important to be able to identify where there are inequities, and you showed that in both of you showed that in yours. But I think even in the absence of being able to do that, even having metrics of the city related to the existence of policies, so to getting some consistency around knowing whether the policies are there to be able to create the conditions for good health would be important. But I agree with you, it's a real challenge, and I think cities really want the data. I think we need to get more standards across countries about how we collect the data, and it's a major challenge and an exciting opportunity as well.
So I don't want to create any frustration. A last question, very, very last? No, we can go for lunch? Okay, so thank you to everybody, and